So some interesting facts before we move on to the more mundane stuff. So the interesting fact is that there are almost 15 lakh different species of fungi live on the earth, which is the largest organism that is available on this earth. It's almost like a few miles of California will be covered with this one fungal strain. So it is the largest organism on this planet. There are almost 300 species of this, which are known to make people sicker. It is prevalent in almost anything and everything that you consume. It's prevalent in soil, water, fruits, jelly, the refrigerator, the humidity. As it increases, even in the drier climate. It is prevalent in the food industry, in the intake of so many items that you undertake. And some of the antibiotics that I and you, or the first ones like penicillin, are derived from the fungi. So it is prevalent everywhere, okay? So is it an animal or is it a plant? Neither of it. It's neither a plant, it is neither an animal. Today's topic, we'll try and just look into Candida, Aspergillosis, and Mucor. Mucor less, Candida more, and Aspergillosis more, because we deal, most of us living or sitting in this room will deal with non-neutropenic patients coming to their unit. So when you talk of non-neutropenia, it will be mostly Candida and it will be mostly Aspergillus. So there are certain aspects of immunity, there are aspects of virulence, the site-specific, and there are diagnostic criteria for diagnosing a fungal infection. Now, there are two basic types. If you look, one is the dimorphic forms, which will change based on the temperature. So at a 25 temperature, it will be something else. At 37, the shape is going to change for the dimorphic. So it is a temperature sensitive. Some of these strains on the left side of the cartoon, you can see they are all dimorphic. But on the right extreme, you will see opportunistic ones which are troubling you. Why? Because the immunity is going down and these are going to hit you as bad as they can. So you can have Candida, you can have Cryptococcus, you can have Aspergillosis. As your immunity goes down, the Aspergillus is going to keep on increasing in your systems. What hits you most is the neutrophil, because they protect you most. So if your neutrophils are going down, you are in trouble. So any patient in neutropenia is bound to have a fungal infection. So always look at the neutrophil count in your patients and anticipate that he is at higher risk for developing of a fungal infection in your patient. So they act upon the Th1, 2, and these cells. So these are important. So when I prescribe or when you prescribe on a bedside, look at the neutrophil count always in your patients. Sites, you are already prevalent. This is prevalent in almost any site, right from the eyes to the sinopulmonary, to the genitourinary, to CNS, to oropharyngeal, GI tract, to cutaneous and subcutaneous. So it is prevalent throughout your bodies. The more eroded a surface is inside, the more endothelium dysfunction is present in your patient, the more predisposed are you towards a fungal infection. So if you have radiation going on, if you have chemotherapy going on, if you have invasive lines into you with TPN going on, if you have broad spectrum antibiotics going on for n number of days, everything is going to lead to an incidence of invasive fungal infection in the system. Diagnostic criteria, now these are based basically on, now this is 2021. I might have taught this in 2005, in 2007, then 2012. It is still proven, probable, possible, and a host factors. But remember, all this literature is coming from the cancer patients, okay? Because these are set by the European Organization for Research and Treatment in Cancer and the mycosis study group. So it is mostly cancer-driven strategy for labeling your patients as, is it a proven case of fungal infection? Is it a probable case where there are more than one host factors available with one microbiological or mycological evidence, plus a one major or two minor criteria based on the site which is involved. So it is based on all these. So when it becomes possible, then you can see changes from the proven, probable, possible. And then there are host factors. Remember, I told you this is all relevant for cancer patients. How many of you are dealing with cancer patients? Just raise your hands. Hardly 2 people. So most of you are going to deal with not this problem, but a non-neutropenic problem. And therefore, I'll try and push the idea towards a non-neutropenic segment more as I go and or walk you through this presentation. Okay, so this is most relevant for cancer. As you become more immunosuppressed, the incidence will change from Candida predominance to Aspergillus predominance. Okay, so the sicker your patient, so if you have started initially with a Candida cover, you ought to think of an Aspergillus if the immunity or the immune structure is going down for that patient during the course of your stay, as well as in understanding what type of patient you have received. Okay, so the more immunosuppressed, that is for SOTs and BMT patients, hemopoietic stem cell transplants. So this will, Aspergillus will become more and more predominant in that segment. Okay, but for the intensive care, which is dealing with non-neutropenic segment, Candida is going to be the most nuisance that they will ever encounter in their units. If you look at the IFI, that is invasive fungal infection. So invasive means it will invade into the organs, it will invade into the endothelium, into hidden sites where you normally will not find them. Therefore, it is termed like invasive fungal infection. You look at the last line, this is meant only for critical care patients. Okay, so any critical care patient means either sepsis, septic shock, multi-organ failure, lot of lines, lot of infusions, and hell lot of things happening, indwelling catheters, dialysis catheters. So these are all critical care patients. Okay, so if you see the incidence of aspergillosis, it is 6.3 per 1,000. I'm sorry, this is the 2014 slide, but I could not get a better one, so I'm still running it. So it is 6.3 for invasive aspergillosis incidence per 1,000 admissions. And as you go for invasive candidiasis, as I told you, it will be higher for patients who are non-hematonc or non-cancer patients. Okay, and if you look at the attributable mortality, why are you afraid? Why are you afraid of fungus? Because it's bound to kill you. It's bound to escalate the therapy costs. It's bound to make it more challenging for you. It is bound to have more and more drug interactions within your patients, and it will become equally challenging to get this patient out, to consider what is the right time I should reduce the medication, what is the right time I should stop the medication, what is the right time I should alternate with liver or renal failure, what is the right time, do I need a therapeutic drug monitoring? So it becomes equally challenging to understand. And over this, there is somebody going to die because of it. And if you look at those numbers below, for critically ill patients, invasive aspergillosis, attributable mortality is 63%. That's huge. You look at IC, it's almost 50%. So again, that is huge. Therefore, I'm telling invasive fungal infections in critical care makes a lot of sense, makes a lot of treatment changes, makes a lot of stewardship aspects. When I go through the slides, I will talk about them. So why is it changing? Now, it is changing. Normally, we believe that Candida albicans is the most predominant ones, but remember, it is changing. All this literature, which is shown on the left-hand side of all these studies that you could ever see, the incidence, this is green is the albicans one, and this is whole pink side is the non-albicans. So with time and with rampant use of some of the azoles that I and you write left and right, specifically for cancer patients, because we are writing prophylactic regimes, it is changing the pattern because you are killing the albicans, so the non-albicans is on a rise. So this pattern is being observed to be changing. And among the non-albicans, you'll find tropicalis, you'll find paracillosis, you'll find glabrata, you'll find cruciae, and other Candida species will be there. So all this is. So this is predominantly happening not alone in India, but everywhere in the world. It is happening because we are indiscriminately writing and using azoles for cancer patients, one, but also for sicker patients. We do not understand sometimes which patient I should write a fluconazole. So this is probably being contributed by this. Therefore, the change. And the incidence, again, this is slightly oldish, but the incidence of these patterns is changing from 5%, 10%, 35%, 5%, and so on. So it is continuously increasing. This is an oldish data. I believe this is slightly more now. I do not have an updated slide on this. So what are your risk factors? Again, any sick patient is a risk factor. Any patient with lines is a risk factor, but there is a host of things. for invasive fungal. When I talk of invasive fungal, I talk of both aspergillosis. I also talk of candida. Okay, I'm talking of both. So these are everything and anything you can imagine in your patient, you will have it. So you can have an organ and bone marrow transplant, you can have a surgical treatment, you can have inherited immune deficiencies, HIV, AIDS, neonates, elderly, intensive care. So sir, chuta kya? Sab to aa gaya. So any sick patient walking into a tertiary care center, into an intensive care, is at heightened risk for having an invasive fungal infection. Okay. Now there are few more things added over this. If you are having sepsis, if you are in septic shock, if you are having multi-organ failure, then this just add on to this element into this entire story, and you will have a fertile media for fungal growth in your patient. Okay. So more septic you are, more shock-like state you are, more multi-organ organs or severity of that organ dysfunction, you are at heightened risk. This is for invasive fungal in total. But there is something more for aspergillosis. As I told you, it depends upon the immune structure. Is your immunity down? So for, say, inhalation, remember candida will spread through my hands, but the spores will travel through the air. Okay. So hand hygiene therefore holds such importance in candida prevention. But for aspergillosis, yes, you will do all that, but air quality of the air coming into your room, into your ICU is so important. You can't have an ICU or a sicker unit in an area where building construction is going on. All this is now aspergillus incidence is going to rise. So if you have a normal host, there'll be no sequelae because of these spores that may enter into your tract. If you have a cavitatory old lung disease, you can have an aspergilloma. If you have a chronic lung disease, you can have a chronic necrotizing aspergillosis. If you have an immune compromised host, you can have invasive pulmonary aspergillosis. And if you have asthma, cystic fibrosis, or atopy, then allergic bronchopulmonary aspergillosis. Just note down the below factors for host factors. Okay. As I told you, IPA means immune is down. So prolonged neutropenia, less than 500 for more than 10 days. Okay. Transplantation, high risk is with lung transplantation, and HSCT prolonged for more than 3 weeks, and high dose of steroid therapy, chemotherapy, advanced AIDS, chronic granulomatous disease. All of them contribute to a risk factor for IPA. But the trouble is that this is all given by EORTC. Again, meant specifically for cancer patients, not for non-neutropenic. We are just trying to take that information, put it into our non-neutropenic, non-cancer patients. Okay. So they categorize it based on a low risk, intermediate high, and further high risk. So if you are dealing with cancer, then you need to risk stratify your patients based on this EORTC and MSC criteria. Remember, it is a continuum of care. Once in a sick unit, once coming with sickness, the longer you stay with risk factors, the more likelihood that you will have colonized with that infection, and the same colonized will change into a pathogenic strain. So it is a continuum that is happening, and therefore you can have the overgrowth, mucosal colonization, micro invasion, candidemia, disseminated candidemias, and if risk factors like diabetes, burn, again, it's a repeat slide, but typical ICU patient will suffer from this. Therefore, there is something called as the colonization index. I need to understand when my patient is walking into the ICU, what is the colonization? So लोगों को समझ नहीं आया कि कितना fungal infection है. यहाँ तो लग रहा है कि पूरा ICU ही antifungal therapy पे चला जाएगा. If you try and look into that. So people tried to look into colonization. How much actually is he colonized with that? So it is CCI, which stands for number of sites which are positive for that candida, divided by the total number of sites which are sampled, and the rate of increase, it is believed, is it increases on an average by 0.1 per week. So every week he stays inside the ICU, it will jump by 0.1. And the higher it is, the more chance this patient will convert from a colonizer, from being a colonizer to a pathogenic. So only sicker patients will get even worse with this. So there are diagnostic challenges. Therefore, people are relying on something कि मुझे पता नहीं लगता क्या करूं. So what are the challenges that you may encounter in invasive fungal infections? Blood cultures, everybody wants to jump to doing a blood culture for candida. You don't do blood cultures for aspergillus because it is organ specific. Therefore, you will either do a bronchoscopy or a bile into that, or you do mostly for those site specific. But for candida, you will look into the blood culture, though gold standard, questionable. because it has low sensitivity. At best, 100 samples sent, only 50 will convert to positive. Why? Because he's already on an antifungal. Second, why? You did not send the right sample. Third, your time period of sending the sample to analysis was not okay. Fourth, your lab was not adept at looking into those slow growing culture growths. Next, I know that it is plus and minus, but I don't know the species of this patient, of this candida. So it will take you another 48 to 72 hours. So on an average, it might take you 5 days to diagnose the species of the candida. 5 days, okay? It's a slow growing, so it will take you 5 days. So these are challenges that you will have. Clinical suspicion ICU, I just now told you, all your ICU patients could be like this. Almost every patient I look into the ICU will be like this. So does the clinical prediction really help me say that this patient could be likelihood of having invasive fungal? So these are non-specific signs and symptoms related with that. Then there is an endogenous origin, as I just told you, from colonized to pathogenic. What differentiates between a colonizer to a pathogenic? I want to treat a pathogenic. I don't want to treat a colonizer, okay? So you have to see that the challenges come here. So therefore, people tried and looked into prediction rules. Now, there are a huge lot of prediction rules available, clinical bedside rules which are available for risk stratification, because I need to understand what risk is this ICU patient of having a candida or an invasive fungal infection. So it is difficult. One, why all these studies on candida prediction rules are center specific. यानी किसी ने डेनमार्क में किया, किसी ने नीदरलैंड के एक छोटे से आईसीयू में किया, किसी ने यूएस के 4, 5, 25, 30 आईसीयूज का मिला के किया, किसी ने फ्रांस का किया. So these are unit specific, area specific prediction rules, cannot be generalized. You have to suit your needs. Look where you stand and take the best out of the lot, because there are a huge number of them. So you can have Lyon score, Ohaman score, Pittet, DuPont. I'm not going to enumerate any of this. There are a huge lot of them. They are not Ostrowski, Zeichner, Haussmann, Poitou, and there are more, even more coming up. So जब इतने ज़्यादा होते हैं, इसका मतलब कोई भी बहुत शानदार नहीं है. Okay? When so many things are coming up. So they will keep on comparing from one center to the other center, one score to other center. Because there are so many, it is more confusing which one should I use as a clinical prediction use in my rule in my ICU. So therefore people, because blood culture problems were there, therefore non-culture based tests have been now being promoted. This is upcoming, this is already going on. When I last presented it probably 10 years back, these were not available in our center. Some of them are now available, like the serum BDJ is available to us. So these are available. These are the beta-2-glucan, the serum Manan antigen and antibody, the Candida albicans germ tube antigen test. Then there are PCR-based tests. Each one of them are more for candidemia. I have not put galactomannan. Galactomannan comes in place for aspergillosis. So that's just an addition to this entire list. Okay. One more thing I need to tell you, because we are looking into the blood as a source for presence or absence of a candida. Sometimes when it is deep-seated, your blood will still be negative, but the patient will be having candida in a deep-seated site. Okay. So it becomes even more challenging. What do I do for deep-seated fungal candida infection? Blood में तो कुछ दिख नहीं रहा. Culture पहले ही कभी नहीं था, अभी भी कभी आया नहीं, लेकिन उसको तो fungal है, deep-seated. So there are challenges to this aspect as well. Okay. So for aspergillosis, remember the first line. If I'm this is definitive diagnosis is based on histopathology. So blood cultures are extremely rare. It is rarely, if you get one, publish it. Okay. If you get aspergillosis in blood, or if you get mucor in blood, publish it. Okay. It's extremely rare. And again, these are based on the EORTC and the MSG criteria. So kare kya? What should I do? Itna problems hai, sir, kare kya? Every patient is like this. So again, this is jumped on from the cancer studies. कि बुखार है सर, fever है, high risk है, prophylaxis दे देते हैं सर, cancer का patient. Again, these are for cancer patients. Empiric, fever driven है, तो prophylaxis में तो डर लग रहा था इसलिए दे दिया. एम्पेरिक में फीवर चल रहा है, नॉट कंट्रोलेबल और नॉट बीइंग एमेबल टू ट्रीटमेंट, फीवर ड्रिवन है इसलिए आपने दे दिया, सब कुछ दे रहे थे, फीवर आ रहा है, यू गिव इट. प्रीएम्प्टिव बेस्ड ऑन बायोमार्कर्स. ओके, क्लिनिकल नहीं मिला, ब्लड कल्चर नहीं मिला, ऑर्गन स्पेसिफिक कुछ नहीं मिला, ब्लड में कुछ ग्रो नहीं कर रहा, नॉन कल्चर बेस्ड टेक्नोलॉजीज लाइक बीडीजी एंड गैलेक्ट्रोमैनाइन. सो दीज आर प्रीएम्प्टिव मार्कर्स and then they will be targeted. Obviously it is based on histopathology. So this is more relevant, as I am repeatedly telling you, this is more relevant for cancer patients, neutropenic patients, not specifically meant for the non-neutropenic scenarios. Okay, so timeline again, 1950, 1960 the first amphotericin B came up, then 1970 it was voriconazole and flucytosine. Then ketoconazole in 1981, itraconazole 1992, and so on and so forth, posaconazole. And the newer ones in 20, if I'm not wrong, 2021 was isobuconazole. So that is oral posaconazole, now moving towards IV posaconazole, and the latest in the bandwagon is the isobuconazole. There are more nanoparticles, which I'm not commenting here. At least this cascade is complete with the presence of isobuconazole in this entire cascade. So if you look into the treatment, what is available to us in terms of treatment, either you can have a cell membrane hitting antifungal therapy, or you can have a cell wall hitting antifungal therapy, or you can have an intracellular killing of the fungal. So amongst the cell membrane, what you and I always remember is the azoles and the polyenes, that is the amphotericin B. These are both of them are cell membrane hitting drugs for antifungals. Those which hit the cell walls are the echinocandins, and those which get into the cell are the intracellular ones, are the mitotic inhibitors like griseofulvin and the flucytosine. Profile. Unless you know your territory, unless you know your area, unless you know the profile of this susceptibility patterns, how am I going to decide which antifungal suits my patient? So I have said that invasive candidiasis. So this profile is for Candida species. S stands for susceptibility, and the R stands for the resistant. This is quite latest, so present in advanced therapies in 2019. So if you look at the green ones, because they're easy to remember. For fluconazole, Candida, as I told you, Candida albicans, it will be mostly fluconazole, okay? Unless you have a resistant strain. So it is sensitive. Sometimes on a higher dose also it becomes more sensitive. Okay, so remember fluconazole is good for Candida albicans and Candida dubelensis. Tongue twister, eh? Okay, forgive me my dialect in some of these. Look at echinocandins. Okay, they are more for non-Candida albicans like glabrata, like Candida tropicalis, like Candida cruziae. Okay, look at the green one, just remember those one, and Candida lusitaniae. So all non-albicans, if you have to take a blind guess, then it always should be an echinocandin. If you are taking an albicans, it can be a fluconazole, provided the patient has not received a previous azole therapy. Okay, or it is frankly showing it is resistant to that fluconazole. Only then you don't take fluconazole as a choice. Look at voriconazole. It is said almost all of them are sensitive, but there are huge issues regarding therapeutic drug monitoring, plasma level variability, and in this segment, amphotericin B, and you have used it so much that it is sensitive to most, if you see, but resistant to Candida lusitaniae. There are a few more of them resistant. I'll just talk about them. Look into aspergillus. Okay, so that was Candida. Now look at the red ones here. So for aspergillus, no fluconazole. For aspergillus, isobuconazole, resistant for Niger. क्योंकि याद करना मुश्किल होगा, तो just remember fluconazole is resistant to all the aspergillus bugs. Okay, just remember it like that. Voriconazole is sensitive to almost all the aspergillus bugs except Niger and Lentulus. Okay, so if you have a species identification, then you can change your therapy. So for invasive aspergillosis, the primary therapy is always a voriconazole therapy, because you see it is sensitive. Why I'm afraid of using, and you shall always be afraid of using it, because it varies too much. I don't know what is my TDM. It just varies. I need a TDM to understand this. So recommendations are use a therapeutic drug monitoring if you want to use a voriconazole. Don't choose voriconazole blindly. Okay. Then for amphotericin B, remember, आप अभी सोच रहे थे कि aspergillus के सारे strains करेगा, लेकिन look at the last ones, the Niger and Lentinus, it does not, it is resistant to the flavors. It is resistant to flavors. So you have to know your antifungogram within your hospital, within your area to understand this. So how will you know this? Unless you push your microbiologist or mycologist to give you this, why will they do it? It is pain in the neck for them. Why will they ever do it? So push them. I need this. Okay. Push them for Candida species identification and the antifungal sensitivity, as well as the aspergillus if you are dealing with high risk cases. Common toxicities. Remember, it is hitting almost so many organs. So just, it is important slide. So I'll just take a minute of yours. All azoles will hit your liver. Amphotericin B hits your liver. 5-FC hits your liver. Echinocandins hit your liver. Okay. So when you prescribe, you should know this. Renal toxicity, amphotericin B is the most prevalent brand used for polyenes. It can be liposomal, it can be deoxycholate. The only difference between the two is that one, you have to pre-medicate with volume, the plain amphotericin B, to prevent nephrotoxicity. If you can do that, then they are equipotent and equally non-nephrotoxic. Okay. So the word is, for plain liposomal amphotericin B, always preload your patient with volume. If you can do that, unless he's an AKI patient, you can't do volumes. So always preload them. Then amphotericin B plain and liposomal amphotericin B are equal. Okay. In terms of long-term toxicity, in terms of the cost is going to be different, but it is equally safe giving an amphotericin B to your patients. Okay. Voriconazole can hit your CNS. It can cause photopsy. It can cause cutaneous photosensitivity. Almost all the antifungals can have cutaneous photosensitivity reactions. Itraconazole, because you give it orally, it tends to create GI gastric acidity related problems. Posaconazole, again, because oral, therefore IV forms are coming, oral suspensions, again, gastritis. 5-FC, yes, gastritis, cardiac. Itraconazole, cardiomyopathies. QTC prolongation, all azoles. Remember this for arrhythmic patients. If your patient is having arrhythmia, try and avoid azoles because QTC prolongation, and you can have more arrhythmogenic potential in these patients. Amphotericin B, again, it is drug infusion related more problems. Echinocandins also infusion related. And 5-FC is, and amphotericin B can all cause anemia and associated with reduced erythropoietin production. So अभी तक जो समझा उसको अप्लाई कैसे करना है, bedside apply. Okay, there are if you really go into this literature in the non-neutropenic segment, you will find lot of things. Okay, लेकिन clinically relevant मेरे लिए क्या है, which is best. So let us see this one. So it shows you Candida colonization. I'll just take you through this. It shows Candida colonization for a patient who is already on antibiotic use, will predispose to Candida overgrowth. If you kill the bacteria, the fungi will grow. Okay, so it is a antibiotic overuse is a common reason. Sometimes in your environment itself, you can have some of these nasty ones. These are CDC red alerts, Candida auris. I think in CCM we encountered in 2017, I think 17-18 one. 17-18 we encountered it, and CDC in USA encountered it in 2016 or so. So almost in a year we were having Candida auris in our ICU at that time. So dangerous, no treatment available, patient is bound to die. No matter what I combine, what dose I use, he is bound to die. Okay, so that is the red alert. So, and then when it is infection, then I need, then I need to understand in terms of Candida, whether it is blood-borne or it is sterile cavity, which is showing Candida. Is it a localized, deep-seated infection like an abdominal candidiasis, or it is pyelonephritis? If it is Candidema, then I need to understand that if the Candida is not clearing away from the blood despite the therapy, I need to look at few sites. One is the heart, and second is the eye. Okay, I need to understand these sides. Both these sides, eye and the heart. I need to evaluate this if the candida is not clearing from the blood despite optimal therapy. So I need to understand this. Okay. So that is for general perception. Now you have a sick patient who has, you believe he has documented candida infection. Then you understand and try to take this information like this. Is he stable? Is he unstable? Stable hemodynamically. If he is yes, and you suspect, you have to give a fungal cover to this. Fluconazole can be chosen if there is no recent fluconazole use. If the non-albicans is not suspected in that case, if there is no intolerance to the azoles, or if you have a known local epidemiology which says that the fluconazole is not resistant, then only you can choose it. If the answer to any of this is no, then your choice is an echinocandin, okay, or a liposomal amphotericin B. Okay, so blind में सबको fluconazole देके, you can't be just happy that I have given him the treatment and he will be okay. So look into hemodynamic stability. Okay, this is important for cancer patients, non-cancer patients. This paradigm. This was available in IDSA 2009. It is still available in IDSA 2016, and they have just moderated it into slightly this form now. The practical guidelines from IDSA 2016. It is almost the same thing. Looking into where you can use fluconazole and when not to use fluconazole as an upfront therapy for an unstable patient. It is almost the same. Just jugglery of a few things here and there. Okay. Abdominal sepsis. I think I have gastrosurgeons here. How many gastrosurgeons are this in this? None? Okay, few of them. Okay. So here we have a case of abdominal sepsis. So what literature is now suggesting to do, this is a 2019 intensive care medicine publication, that if you have a patient of abdominal sepsis and you are expecting, and he's non-neutropenic and a non-transplant patient, and then you do an invasive candidiasis versus candidemia. Invasive means more deep-seated. Is the risk for having invasive candidiasis more than having the candida in the blood? Then you categorize these patients as high risk, and the chance that these patients are going to have an inside candida is very high in this group of patients. PCR based test, if available, use it. If not, then go ahead with the therapy depending on the stability. Antifungal therapy and source control is always important. They are utilizing this newer strategy of BDG, which is beta-D-glucone. Now there are cutoffs which I don't want to talk in this audience. There is 80, there is 120, there is 200. So जब high risk है पूरे ICU में कैंडिडा का, तब ये बीडीजी हेल्प नहीं करेगा, वो तो सभी को है. लेकिन अगर ये प्रेवलेंस लो है कैंडिडा का इन्फेक्शन का उस एरिया में, यानी लेस देन 5% है लो प्रेवलेंस, तब ये बीडीजी हेल्प करेगा. ओके, सो एज आई increase the cutoff from say 80 to 120, 160, 200, it will become more and more specific for my case. Otherwise, BDG karoge, it is a common biomarker for all and what fungal infections. तो कितने पे उसको मानना है, that is important. Single time value मानना है या twice weekly मानना है. Again, there is literature evolving कि one time is enough or I need to repeat the sequencing again. So if with treatment, the BDG, if you have taken, if the BDG is falling below 80, then I can stop my treatment for abdominal sepsis if it is invasive candidiasis. So you have to ask your microbiology unit to give you BDG assays for this particular. Now, if your answer is no, and there is candidemia is more than the invasive, यानी deep seated नहीं है, blood में ही केवल candida grow कर रहा है, then likelihood है, you can use colonization index, the candida score, you can exclude other infections, alternative diagnosis, and then you can use a BDG score. Remember this BDG again, just look at those values. वहाँ 80 पे बात हो रही थी, and suddenly on this side you are going with the BDG of a very high levels of 250, because as you go up, your specificity is going to be more correct for these patients. Okay, and then you can start him on antifungals depending on stability. If unstable, echinocandin is your choice. If the levels are not that threatening, then you can have watchful expectancy in your patients. But remember, you have to reevaluate this patient. It is not a one-time and all-time therapy कि एक बार चालू किया और 10 दिन के बाद भूल गए कि हमने इसको antifungal दिया था. So every 5 days you need to reevaluate. So this is the current style of doing it for abdominal sepsis patients. Then there is another one style which is now being promoted. One is the diagnostic driven pathway. Again, both of these are using BDG assays. Okay. So I will not go through them. Most of them are using BDG assays. Okay. Or galactomannan assays for telling where should I go once I start the treatment. Okay. If the levels are going up, if the levels are coming down, should I stop it? So these are newer biomarkers which are used for driving your antifungal therapy. Okay. You can just capture the slide and use it for your further reading. Again, the course has to be shorter, 5 days. Previously था कि 10 to 14 days दे देते हैं minimum, या blood culture negative होगा उसके बाद 14 दिन तक देते हैं. ठीक है, अभी भी वही है, यानी ब्लड कल्चर पॉजिटिव था, ब्लड कल्चर नेगेटिव होने तक आपने दिया और उसके 14 दिन आगे तक आपने दिया. इट इज स्टिल देयर, लेकिन कितनी बार ब्लड कल्चर करना है? पहले था डेली करना है. एवरी डे यू हैव टू सेंड अ ब्लड कल्चर फॉर कैंडिडिमा क्लियरेंस. कौन करेगा? हमने तो नहीं देखा 20 साल में क्रिटिकल केयर करते हुए कि कोई रोज भेजता है. नोबडी सेंड्स इट. सो व्हाट इज मोर प्रैग्मेटिक? एवरी थर्ड डे, एवरी फिफ्थ डे. सो नाउ दे हैव wisely gone away with that, and the guidelines do not comment. The IDSA 2016 does not comment anything now. Even the newer ones from the ICU are not commenting on what is the frequency of doing this. But they do say if it is negative, then another 14 days is your therapy. Okay? For the antifungal. For aspergillosis, just 2 more slides. It depends upon high, moderate, low, which I just told you. So the more severe, then mycology, which is more important, then imaging, then so it is a clinical, imaging, and mycology based and risk stratification based treatment guidelines for invasive aspergillosis. And this is what is being recommended as primary therapy, alternative therapy. So for invasive aspergillosis, the primary therapy will remain voriconazole. Okay. And for all the like CNS aspergillosis, cardiac aspergillosis, or aspergillosis infection of the eye, it will combine a systemic voriconazole or oral plus an IV intravitreal amphotericin B together. This is the primary therapy for invasive aspergillosis, maybe of lung or extra pulmonary. Okay. And then there are alternatives. Will always be a liposomal amphotericin B. You see it all everywhere. The alternative is liposomal. With the advent of isovuconazole, that has now come up, and isovuconazole also stands as an alternative therapy for your patients. Localized forms, अलग-अलग जगहों पे fungal infection हो रहा है. IDS से ये 2009 का है. I could not get I did not have, sorry, I could have got it, but I did not have the time to get the 2016. But I believe it is not much change because only isovuconazole have jumped into this market. None of these drugs. So for pyelonephritis, it is either fluconazole or it is amphotericin B plain. Never give liposomal amphotericin B to a renally or a pyelonephritis or fungal pyelonephritis. Okay, it does not concentrate. So it is amphotericin B. Urinary fungal balls, again it is amphotericin B or fluconazole. Candida osteomyelitis, it is again fluconazole or a liposomal amphotericin B. Septic arthritis, it is again fluconazole or liposomal amphotericin B. CNS infection, it is again liposomal amphotericin B plus minus flucytosine added to that. Endocarditis, it is liposomal amphotericin B. Sporadic thrombophlebitis, it is again liposomal amphotericin B. Endophthalmitis, it is again plain amphotericin B plus flucytosine or fluconazole or liposomal. So these are your choices if a local site related problematic patient you have. This is what is being promoted of late in 2019. You have almost, this is like what you are doing in last 2 days is an antibiotic stewardship program. Okay. So the newer things are antifungal stewardship programs. Now they are more difficult. Antibiotic stewardship is much easier. Okay. This is much more challenging. Lot of interactions because I just now I told you it could be cancer patient, it could be non-cancer, it could be prophylaxis, preemptive, kab kya karna hai, site se nikalna. So it is very, very challenging. It looks into few things which I've just touched upon, like one, like the high rate. Okay, like the de-escalation, kitne din dena? What do you mean by de-escalation? IV से oral form change किया, de-escalation. Voriconazole से fluconazole change किया, de-escalation नहीं. Okay, so you can't change the same category into the oral form, that is not considered. Okay, so you please note this important. Amphotericin B था, मैंने fluconazole change कर दिया. Voriconazole था, मैंने change करके amphotericin B पे या कुछ और modulation पे चला गया, itraconazole I've not the azoles, but another one. I can't use a triazole for a downstepping of another triazole. So that is not considered de-escalation. Okay. Then there is early diagnostic tools, BDJ I've talked about. Then there is हमारे यहाँ पे microbiology में Malditoff they are doing. I'm not aware whether they are doing PNA fish or not. Mohan, PNA fish they are doing? PNA fish? Okay. Malditoff, I think they are doing it. Yeah, Malditoff is, so these are newer things, Malditoff for BDGAs and other things, PNA fish, again for species identification. Then you take a blood and directly assess it on the bedside itself, like PCR-based platforms, like the T2MR, that is a miniaturized form of PCR and magnetic resonance for Candida detection. Okay, it detects 5 of these species of Candida. It will give you a result in 5 hours. 5 species, 5 hours, T2MR. Okay, it is a miniaturized PCR with magnetic resonance technology impregnated into it. So that is T2. These are newer things that are available to us. And if you have to do a galactomannan, then it can be blood galactomannan or a ball lung related galactomannan. And obviously, jitna close site ke jayenge, wahan pe acha yield aayega. So you go into the lungs, get a ball, that will be more better than doing a serum ball. Okay, so these are newer things. And another new thing that has been now being emphatically promoted is TDMs only for one drug, that is voriconazole. They are not pushing the idea for TDMs for all, except voriconazole. They have not recommended it for anything. ID specialists, I don't know how many of them are present in India. This is a huge bandwagon to be achieved. So we are not having dedicated ones, so I can't comment on this. So these are newer things that are coming up. You can read this beautiful article which talks on a lot of things. I'll sum it up. I've taken a few more minutes than required. So both invasive and invasive aspergillosis are most common IFIs. IA is more prevalent in immunosuppressed. IC is commoner in non-neutropenic. Risk stratification based on whichever clinical prediction rules you use can be done, is essential to management. Culture-based are not great, so non-culture-based technologies are being adopted now. And finances, because each of these antifungal is a huge cost, because antibiotic bhi de rahe honge, antifungal bhi de rahe honge, huge dosing bhi de rahe honge, and length of time bhi bahut de rahe honge. So an antifungal stewardship program is the newer thing and more promoted by almost all the guidelines and societies now. It is more relevant to us now. Thank you.